So good evening, good morning, good afternoon, depending on where you are. And welcome to this seminar, which is Strengthening Nepal's Response to Fight the Pandemic. But it is really, truly global in nature because we have colleagues from Canada, we have colleagues from Norway, we have colleagues from Nepal, we have colleagues from Thailand, India, Africa. So we're really very pleased to have you all on board. And apologies to those who have to wake up too early and to those for whom it's rather late in the night. So we have an extremely exciting program for this two-day webinar. And I'd like to first of all thank the co-organizers of this webinar. It's the University of Oslo, it's McGill University, Tribhuvan University, Kathmandu University, and of course the host Empower School of Health. We're very pleased that we could get all the partners together for this webinar. And for those of you who are familiar with the Mental Health Conference, every year the partners, which was traditionally University of Oslo, Tribhuvan, McGill, had a tradition of having the mental health conference every year in October at the Shrine. And this year, because of the situation and because of the circumstances, it was not possible to have this annual event. However, we were not to be defeated by COVID, and therefore we have tried to replace our two-day conference with this webinar on a very important theme today. So very quickly, I'm going to take you through the agenda for the day, some housekeeping announcements, and then we'll get started. So today, the way the webinar is planned, it's in two parts. The first part will be an introduction by all the organizers and the co-organizers about their organizations and their response in terms of COVID-19. And then we will have our keynote address, and we're extremely privileged to have the WHO representative in Nepal, Dr. Rajesh Sambhaji Rao Pandev, who's recently arrived to the country. So it's really a treat and a privilege to have him on board. And this will be then followed by the panel 2, which will focus on mental health and culture. And we have our real veterans and stalwarts like Professor Lawrence and Professor Jaswant, and of course, our colleagues from Norway and Nepal who will take part in that. And then we will summarize day 1 for today. Next slide, please. Some housekeeping announcements. All of you will know, please mute your microphones. I think most of you can't unmute them anyway. And turn off the video. The only people you'll see are the people speaking, except for the Q&A, when we'll try to have all the panelists visible. And then we'll forward the questions to them. We'd like you to ask your questions using the chat box. There's a chat function. And please be active in the chat. One of the good things about webinars is that we don't have to wait until the end of the presentation to ask questions. You can already place your questions in the chat. You can also say hello and greet friends. And I'm sure a lot of you know each other, and this is a good way to network while we're at this webinar. We also have some exciting polls, and it's important because we want to make sure, one, that you're awake, and two, that you are not only passive listeners, but also participate actively in the seminar. The webinar will be recorded and will be available in the Empower School of Health YouTube channels. So if you miss something, you can always go back to it. The slide deck will also be shared with all the participants. And we'd really like to get feedback from all of you so we can become better at webinars. And at the end of the webinar, you will all receive a certificate of participation once all the steps are completed. So with those few housekeeping announcements, we are ready to go. Next slide, please. Are we not able to get to the next slide? For the speakers, housekeeping announcements for you. We've already joined, all of you, so that's great. Please turn on your cameras when you're speaking and mute your microphone when you're not speaking. and adhere to the webinar schedule speaking timelines. And what I will do is, while you are speaking, I will not be visible. But when you suddenly see my face pop up again, you know that your time is running out. So that will be an indication for you to stop. I don't have the red and the yellow cards that we usually hold out at conferences. So you will just see my face again. Thank you. So we finished off with the announcements. Now on to the program for the day. And the first part of this is really introduction of the partners and the contributors to this webinar and to the COVID-19 response. So the first speaker for the day among the partners, can I have the next slide? There's a bit of a time lag on that. The first panelist today is my good friend and colleague, Dr. Suraj Thapa. And he is very well known both in Nepal, where he's originally from, and also very well known in Oslo, Norway, and with the McGill group as well. So he is basically, I'm not going to read out his entire CV, and I'm not going to do that for other people either. But a very important task that Suraj has is he's the project lead and the head for NORPART. And NORPART is this collaboration between Norway and Nepal. And it has really been a very important collaboration in higher education for global mental health. And as you can see, his interests are in mental health and global mental health. So Suraj, now the floor is yours, please.
Thank you very much, dear Bernadette. Good morning, Canada. Good afternoon, Norway, and good evening, Nepal, and also other places, depending on the time zone. It's a great honor to be a part of this webinar, and I'm always thankful to my great colleagues like you, Bernadette and Ritu, who have been doing a lot of work, a lot of preparation for this webinar, and my colleagues at the McGill and my colleagues at the Institute of Medicine, Department of Psychiatry. As Bernadette has already mentioned that we have been organizing annual conference and seminar for the past 10 years almost in Kathmandu. And it was great to have McGill together with us for the last few years. And we had already planned a seminar this year on 19th and 20th of October. But because of the COVID-19, we had to turn it down. But then, like we've been learning every day, we have found different new ways of dealing with the threats given by this COVID-19, and this is a part of it. So I'm going to tell you a little bit about the project and then the challenges brought by the COVID-19, and my colleague Professor Sarojwaja will tell more about how we've been mitigating the challenges regarding our collaboration between Norway and Nepal. Next slide, please. Just to give you a scenario, outline of the situation of COVID-19 in Norway, and compared to the some other countries like US or UK or Southern Europe or even Nepal and India, it's it's very minimal. Almost half the population have been tested for COVID-19. 2.3 million people have been tested, and only 36,500 are found to be positive. Only 331 have been admitted in intensive care units in Norway, out of over 1,700 who have been admitted in different hospitals. And for today, we have not more than 200 patients admitted in different hospitals. So this is not even big figures compared to the other countries and other which have been really struggling with this COVID-19. And so far, only 351 deaths have been reported in Norway. And the first wave of COVID-19 came in from in March and April, and then from middle of the March to middle of May, the country was almost lockdown, but it was partial lockdown compared to what you've been doing in Nepal or India or other parts of the world. And now recently we've been experiencing the second wave, but it's still the scenario, as I said, it's not that worse. As most of them, for example, the universities have been doing the digital teaching, and then some of the clinics have also been trying the digital consultations. And as we all know, that COVID-19 has given a lot of threats, but at the same time, it has also made us really think or rethink about different things, how we've been living, how we've been thinking, and then how we've been dealing with different problems. So this has also given rise to so many different research projects. And as you've already heard that, we've already two or several, 3 different vaccines which have already passed the trials. And there are so many publications related to COVID-19. And mental health has been of a great focus. And then this is also going to change the how people have been prioritizing the mental health while dealing with the health problems. So this is a good part of COVID-19. Next slide, please. Little bit about the NORPART project, which is a a project between Norway and Nepal, basically aiming to strengthen the quality of education in higher education and mental health. So what I mean is that at the master level and the PhD level through academic cooperations. Next slide, please. And this project started in 2019, and we had a lot of activities. Last year, we had a visit by the Dean and the Vice Chancellor of the TU to Norway. And this year, we had planned the reciprocal visit to Nepal. But then because of the COVID-19, all the visits, all the exchange programs had to be canceled. And we have different, several other project partners, even though, University of Oslo and Tribhuvan University are the main partners, but then we do have University of Bergen, University of Tromsø, and Oslo University Hospital, and then County Children's Hospital, and some NGOs in this project. Next slide, please. We've already completed the revision of the master curriculum at the Department of Psychiatry, both for MD Psychiatry and MPhil Psychology. And then this year we have started to write a curriculum for PhD, because one of the ambitious aims of this project is to start a PhD in psychiatry and mental health at the Institute of Medicine in Kathmandu. And as I said, we have also staff mobilities and mobility of the students between Nepal and Norway. Next slide, please. And we are also developing some joint programs, joint training. University of Bergen has done a tremendous job, and then they have, even though we are supposed to receive 3 psychology students to Bergen, and then 5 MD psychiatry residents to Oslo, but then because of the COVID-19, so the Bergen has developed a new course, digital course in global mental health and crisis management, and they have been able to enroll even more students from Nepal, which is a positive side of all these challenges brought by the COVID-19. And then we've been also working in developing research projects. We have already 3 PhD students from Nepal who have already been enrolled in PhD programs, and then fortunately some of them have been able to follow or join some of the obligatory courses through digital platforms, which is also a good part of brought by the COVID-19. Next slide, please. And mobility is the major focus of this project, but then again, this is the biggest challenge that we've been facing these days. But then again, we have found some alternative solutions, which Dr. Saroj is going to tell a little bit about in his session. But then I can briefly tell you that we've been able to negotiate with our funder, and then they agreed that we can build up the IT infrastructure at the Department of Psychiatry and Psychology in Kathmandu, so that we can use the digital methods of teaching and exchange of conducting several meetings and webinars and so on. So that is that is also a good development when we discuss about the problems, and then we are able to find some kind of solutions to the problems brought by the COVID-19. Next slide, please. Yeah, I already told about this popular October conference. So like for the last 2 years, we have had a focus on spirituality, culture, and mental health, which was very, very popular. Last year we had almost 20 presenters from all over the world. And as I said, like we had already decided the date and even the like contest for this conference, but then this has to be cancelled. And then now we have partly replaced that conference through this like webinar. But then hopefully next year we can see each other in Kathmandu. Next slide, please. Yeah, this is just to say like how it was when we started our small seminar between the two universities with help from the Northern Psychiatric Association. But then in the past few years with the support from this NORPART project, with the great support from our colleagues, Professor Lawrence and Professor Jaswant from McGill, and from other colleagues all over the world, we've really been able to make this a great event, and we're going to continue it hopefully from next year. Next slide, please. I think that is like the end of my slide. So I just want to like thank you everybody for your kind attention, and then I'll be back in next session or for any questions and comments. Thank you very much.
Thank you so much, Suraj. And it's really nice to see you from Norway in Kathmandu, even though it's digital, and for taking us through that journey that NORPART has had. And this journey from Norway to Nepal would not have been possible without the support and the driving force of our next speaker, who's Professor Saroj Ocha. He's the head of Department of Psychiatry and Mental Health at the Institute of Medicine, Tribhuvan University. He has really been at the forefront of bringing mental health on the agenda in Nepal, which is not a very easy task. And he's not only very, very competent and qualified, as you can see from the slide in front of you, but he has that engagement to make sure that mental health and those with mental health disorders are not forgotten. So Professor Saroj Ocha, the floor is yours.
Thank you very much, Professor Bernadette, for your introductions. Dr. Suraj, thank you very much for your just presentations. This webinar, Tribhuvan University of Oslo, McGill University, in partnership with Empowered School of Health, Kathmandu universities, organizing the 2 days webinar series. As our colleagues already mentioned, the October conference in Kathmandu, we started this conference for more than 7 years. Because of COVID-19, today we are here. Thank you very much and welcome all the participants from different parts of the world. I would like to welcome all the participants. Special thanks to the WHO new representative of Nepal, Dr. Rajesh Dr. Rajesh, for your kind time and your keynote speech after these presentations. On behalf of Department of Psychiatry, during this COVID-19 pandemic, the next slide, please. My format of presentations is I will give the brief introductions, COVID-19 scenario in Nepal, then departmental activities during pandemic, especially we had collaborations with different organizations, especially WHO, Nepal, and the Ministry of Health and Population also. And my presentation will be focused on also the NORPART project activities, and finally the government response in mental health. During this pandemic also, Nepal government has taken a huge responsibility and given us the huge responsibility. So I will be discussing about the government response and finally the conclusion. Next slide, please. As everybody knows, December 31st, 2019, WHO contribution in People's Republic of China were alerted by the cases of viral pneumonia of unknown cause. And this viral pneumonia was determined by novel coronavirus on January 9th. interestingly, after the 4 days of these determinations of this coronavirus, the first case of novel coronavirus was diagnosed in Nepal. A 32 years old man, a Nepalese student who returned from Wuhan University of Technology, Wuhan, China. And in 30 January, WHO declared the emergency of this pandemic, this coronavirus. Next slide, please. Talking about COVID scenario in Nepal, the first case in January, and in 11 months times, among the 30 million population of Nepal, the total cases on 19th November is more than 200,000 cases. And if you see the recovery cases, it's more than 86% recovery case, and total infected case is around 13% still. And if you see the death is around less than 1%, 0.59% of the death. So we are having a death in Nepal, around 20 deaths per day because of coronavirus is still there. Next slide, please. And when you see the COVID scenario in Nepal, according to the sex-wise, male is to female, it's almost 2:1 ratio. Male is to female is 2:1 ratio. And if you see the all the ages group from 0 to 10 to 80 above, the male is more than the female in COVID positive cases. Next slide, please. And one of the articles published in Journal of Nepal Medical Associations, that mental well-being during the lockdown periods following the COVID-19 pandemic in Nepal. This was the descriptive cross-sectional questionnaire-based online survey. More than 550 participants were included, and 40% of the participants reported WHO well-being index score less than 13. That is indicative of poor mental well-being. Next slide, please. So under these pandemics, during these pandemics, our institutes, our departments, as in March 11, WHO declared state of pandemic. And in Nepal, from 24 March to July 21st, more than 4 months, Nepal was in lockdown period. And during the lockdown periods, initially we had to work despite the limited resources for safety measures. Our services were limited to the inpatients and emergency only, because our hospital is a tertiary hospital in Nepal, and OPD services was provided by the telephone call, and doctor on duty roster of 24 hours doctor on duty rosters was circulated through the social media. And during this period, we have developed, our department developed the COVID-19 pandemic operational guidance. And this is to ensure the safety of all the staffs and residents during the pandemics. But unfortunately, our faculty doctors, our faculty members, our residents, our sisters, they become positive. But fortunately, all of them recover from the COVID. And during this period also, emphasis was given on establishing the telepsychiatry service. Next slide, please. After the lockdown ended, our hospital started all the service resume, but because of our hospital was providing both the service COVID and non-COVID, the patient's flow was very low. But still, our institute is running different medical courses. So we started our classes for undergraduates. We started lecture classes for postgraduate MD residents, MPhil clinical psychology resident, bachelor level public health students in online platform throughout the periods. And also the thesis guidance and supervision was continued. We also continued the examinations of undergraduate or postgraduate in our departments. During this period, we had the collaborations and special collaboration with WHO Nepal. Thank you to WHO Nepal. We have WHO Nepal provided technical support, supporting mental health and psychosocial well-being for frontline health and social care providers under the guidance of the Ministry of Health and Populations in collaboration with WHO Nepal and TPO Nepal. The objective of this project was to provide a digital platform for mental and well-being of frontline healthcare providers in Nepal. And the duration was from May to November 2020. Next slide, please. With the help of WHO Nepal and TPO Nepal, this mental health and psychosocial support service to frontline healthcare providers, we have established the websites mewellnepal.org.np. And under this project also, we have conducted a 6 webinar series on mental health and stress management by the faculty members during the pandemic for healthcare workers of Nepal. Next slide, please. Similarly, in the collaboration with CBM Nepal, we have started the on the occasion of World Suicide Prevention Day on 10 September, we have started launching the toll-free suicide hotline number in our departments with the help of CBM Nepal. And this is the first time in Nepal that toll-free number we have started. Next slide, please. NORPART activities, this is, as Dr. Suraj already mentioned, series of online meetings via Zoom among the major stakeholders, University of Oslo, Bogians, Dr. Suraj Thapa, Dr. Bernadette was there. Infrastructure strengthening to set up this digital online learning in the departments. Similarly, online supervision of PhD supervisors and this Dr. Saraswati was continued. The second PhD candidates admissions granted from the University of Oslo. Next slide, please. Similarly, the first Zoom meeting of PhD curriculum conducted. MPhil candidate selection was done, and online crisis psychiatry online courses started from the University of Bergens. Dr. Mita Rana was coordinating. Next slide, please. So, government, Prime Minister of Nepal, Right Honorable KP Sharma Oli, called us for interactions to promote mental health in Nepal. Next slide, please. And during this meeting, Prime Minister, Health Minister, and all the policymakers of Nepal government, Health Ministry were there. And the positive steps towards effective implementation of national mental health policy, mental health legislation, and national suicide prevention strategy have been instructed by the governments. And also to increase the psychosocial support to general population people who are living with fear of COVID-19 also we started. Next slide, please. So in conclusion, stress in COVID-19 is inevitable. A feeling under pressure is likely an experience for all of us. The most important was changing attitudes toward need of mental health and well-being, and emphasis on need of telepsychiatric services to overcome the barrier of limited resources, accessibility, availability of mental health services. An important part is managing of mental health and psychosocial well-being during this time is as important as managing the physical health. Now we are adapting to a new normal during these pandemics. With this next slide, thank you very much. I'm sorry a bit late. So this was the last year we were together. With this, I would like to conclude my presentation. Thank you. Over to Dr. Bernadette.
Thank you so much, Dr. Suraj. I think you really managed to give us so much information in such a short time, and you really highlighted how important mental health has been during the COVID-19 pandemic. And the response has been really active, but of course, there are so many unmet needs, and we can discuss that in the discussion session of part 2. But this was a great start to get everybody thinking about mental health. Thank you so much. I would now like to ask our next panelist is Dr. Biraj Karmacharya. He's the Director of Public Health and Community Projects at Dhulikhel Hospital, Department of Public Health, and also the Kathmandu University. And he has had, Dhulikhel and Kathmandu University have also a long-standing relationship with Norway, and there has been a long-standing relationship between Kathmandu University and Dhulikhel Hospital with NTNU. And we know that they're also involved with training of master's students, and Dhulikhel Hospital, besides the education part, has also been a very active partner in on-the-ground outreach programs and tackling at the grassroots level the effect of the COVID-19 pandemic. So without much ado, I would like to give the floor to Dr. Biraj Karmacharya. Biraj, the floor is yours.
Hello, namaste everyone. Thank you for giving this this wonderful opportunity to share some of our experiences. Today, I'm going to highlight a little bit about the institutional response to COVID-19. My previous speakers did a fantastic job explaining the COVID scenario in the context of Nepal. I'm going to give it a look through the lens of an institution, how it started. Because basically, when we started with the COVID problem, it was as if in a situation that you are in a war zone, caught utterly, without any prior information or preparation. So we had to prepare ourselves to face the scenario, and we did that. We tried to gather our teams and initiate some responses, primarily in three major areas. One was institutional response, focusing primarily on the clinical part, so that include all the hospital preparedness activities. And we had one team that was entirely focused around the community engagement, especially in the town of Dhulikhel, where we tried to engage with the municipality, the local people, and so on. And then another team was primarily involved, in collaborating with the government. And we had to start it from the scratch, because at that time even the government was struggling to come up with guidelines and protocols, and the communication channels and so on. So as an academic institution, we proactively came forward and worked with the government in terms of epidemiological assessment, developing protocols and training programs, for example, in case investigation and contact tracing and so on. So what I would like to do is I would like to show a very brief video of all that we have done, and then I will summarize it in a closing slide after that. Ritu, can you play my video?
Admin team, could you try again? There's nothing showing. If you can see if the video is working, if you're struggling, if there's any technical problem, please let us know. Yeah, great, we can see it. Viraj, is there sound as well? I don't hear it.
Yeah, Ritu, can you start it again with the sound? Yeah. Yeah, thank you very much. So let me just summarize our experience from a very personal perspective. I think one of the things we learned was that in scenarios like this, we need to get out of our comfort zone. It is always, we come across situations of confusion, and we expect someone to lead it most of the time. But what we tend to forget is that, sometimes our own initiation can do amazing impact in the overall institutional response. So, but one has to get out of our comfort zone for that. Second thing is that we need to understand everyone is very overwhelmed in scenarios like this. It is very easy for for people in academia, for people who are in the field of different expertise, to feel that their voices are not heard by those in policy or in power. Uh, so we have to be mindful of that, and it is the perseverance that ultimately pays off. So we really need to be mindful of that. The third point is the need of effective and regular communication. One thing we learned very early on was that partnering with the local stakeholders as well as national stakeholders as an institution was very key to the success. And also it was a very key lesson in terms of getting support, and also getting acceptance of our activities by them. So we have to go for synergy with them. We should also be aware that failure is inevitable, and we had lots of problems, and there were times when we had terrible shortage of the PPEs, especially in early part of the pandemic, and then later on we had issues with the scaling up of our PCR testing capacities and so on. So there were lots of challenges, but we managed to tackle this step by step, and ultimately we came into a situation where we could really perform to the best of our capacity. And then the final point is that, especially in the context of Nepal, many of you might know that Nepal recently got into a very decentralized health system. Historically, it has been a very centralized health system, but it was very recently decentralized, and it was the new system was still very fresh, and there were not enough people, and there was not enough capacity to handle the scenario. So this posed a huge challenge. But over the time, we learned, and we traveled to these local areas. We traveled to the provincial health offices and so on. And then the beautiful thing that we learned was that over the course of time, these local and provincial governments could really step up, and and they could take these responsibilities in a pretty astounding way that would otherwise be very unexpected in a scenario like this. So I would consider that the biggest challenge as well as the strength happened to be in the context of Nepal was a decentralized structure. And the final point is that, especially because most of us today, we belong to to the world of academia. My final message is that generally, as as academicians, we tend to pursue our actions primarily in the generation of knowledge and the dissemination of knowledge. But I believe that there's something more we can do, especially in these situations, and that is the implementation of knowledge. So I think that is exactly what I mean when I say that we need to get out of our comfort zone and step on the field and try to do the best from our side. Thank you very much. I would love to have questions later on.
Thank you so much, Biraj. Your wish has been granted immediately. There is a question in the chat for you. So if you can look at the chat, try to answer the question from one of the participants on chat. we've said that we will answer questions as they will come on chat. But I would really like to thank you, first of all, for that presentation that really put faces to the numbers and gave everybody an idea of not just the technology and what it takes, but also the human effort that is required. So thank you very much for bringing that in addition to what Dr. Saroj presented and to what Suraj has presented. And we also look forward to having a discussion about how this can be taken forward and how the synergies can be exploited. And now for our next speaker. And the next speaker is the host, I would say, as the director, founder of Empower School of Health and Empower Group, Professor Paul Lalwani. He is the founder and director, and he has been working for several years with ministries of health, ministers of health in across several continents, and has been formerly, he was working for the Global Fund, and of course his area of expertise is in supply chain procurement, but now it has moved not only to supply chain and procurement, but to digital learning, and in particular to leadership. So Paul Lalwani, the floor is yours.
Thank you very much. Very inspiring indeed. And I'll pick up on the last, sorry, can you hear me okay, first of all?
Yes, we can hear you, Paul. Thank you.
Thank you. And I'll be sharing my screen in a minute, but I just wanted to emphasize and highlight the point that was made by the previous speaker, and very inspirational video message, and the fact that we should make sure that knowledge is actionable and take it out to the health professionals, the health workers, and even the community themselves. So, and it's an area that we've been striving to work towards. And we'll share some examples of what we are doing with various ministries of health, with the World Health Organization, and civil society as well. So I'm just going to share my screen. Let's see if this works.
Yeah, we can see it. You just have to make it into presentation mode. It's smaller right now.
Yeah, tell me if this works. Did I share the right screen? Can you see me okay? Or
so there are small slides at the bottom, I think.
Hang on a second. If it's still small, let me, how's it now?
It's the same.
It's,
yeah.
Sorry, is it a full screen or it's not full screen?
Now it's a full screen. We're good.
Okay, good. Thank you. So, so Empower's contributions, very briefly about Empower. Let me see if I can change my own screen here. Of course, the computer decides to freeze up a little bit. There we go. No. Everything was working rather smoothly. One more time. So while the computer decides to respond to my instructions, just to mention that our focus, Empower's focus, as with the name of Empower, is exactly that, is to transform the way people learn, work, and save lives. And we leverage technology to try and bring scale across not only at the center, but to the last mile as well. Okay, in terms of our footprint and our outreach, large-scale capacity building, we've reached out to more than 200,000 learners, more than 100 plus countries, and then delivered more than 1 million hours of training, capacity building, and we'll talk about the impact measurement as well. What makes us unique is that we started off as public health professionals and supply chain professionals, But then over the last decade, we've added capabilities in instructional design, teaching methodologies, graphic design, technology and learning platform development, and of course, leadership as well. What we realized is that we cannot bring transformation and change unless we also focus on leaders. And in fact, one of our mentors, our lead mentor, is the former president of Ghana, John A. Kufuor. His Excellency is one of our mentors, and not just to the team and the faculty members, but also to many of our learners who have access to him as well. Our domain areas, leadership, as I mentioned, various areas across global health and supply chain. Very glad to see Dr. Pandev, who will be speaking next as well. We've had a chance to work with him in Timor-Leste. New product introduction, big issue, and especially now when we talk about introduction of new vaccines. And if we're going to be vaccinating, India being one of the largest markets for vaccines, the largest number that they introduce on an annual basis is about 60 million vaccines for infants, and that has to jump to more than 1 billion immunizations per year, which they need to be done, which is going to be very, very challenging. So new product introduction is an area that we focus on. Medical laboratory diagnostics and health workforce strengthening. Our learning approaches, as mentioned, from e-learning, gap analysis, learning management systems, which rely on technology, capacity building on latest WHO tools and CDC, and leveraging really good, strong content, policies, manuals, and guidelines. And then we work with partners. In India, for example, we're working with USAID, the Ministry of Health, and WHO to translate tuberculosis policies and guidelines into actionable and usable learning material all the way out to more than 200,000 TB workers. When we talk about capacity building and learning, and especially bringing digital learning, there's a framework that we apply and deploy. When people think about e-learning, unfortunately, it's quite simplistic, and they think that it's basically, if you have an e-learning course, people can either access it or not access it, and that's pretty much it. Unfortunately, it doesn't work that way, and there needs to be a strategic approach from understanding, first of all, who the audience is. Whom are you trying to benefit and impact? How will you reach them? How will you create content that they will be able to understand and use? If you're targeting a community or a community health worker, you need something really simple. You need something that's more visual as opposed to more words. Chances are they are not highly educated, and they don't have a computer, and they don't have full Wi-Fi access. So we need to simplify it and make it engaging and interesting. So there are different approaches, different styles, and creating the content doesn't mean people will actually read it, use it, and apply it. And that's where a whole amount of science is needed there as well. And that's the support that we provide to various organizations. So the example that I wanted to share, this is a project that's been ongoing from this year, will continue next year as well, working across all 11 countries, where we are working, again, I'll back up a little bit, the Global Task Force on Access to Health Commodities related to COVID, led by the World Food Programme and WHO jointly, is working across various countries, and GOARN, which is the Global Outbreak Alert and Response Network, and its secretariat is at WHO, is helping increase access, knowledge, information, and products of PPE across these 11 countries. So we are working with them to design, develop content, to make sure this content is understood. We provide trainings, online trainings for the moment, which is the easiest and the fastest way. We're taking rather complex but very useful tools that have been designed by WHO for forecasting. It's called the ESFT, and the versions keep changing. It's gone from version 1 to version 2, and now it's version 3. We're creating an online course, an e-learning course, to help individuals understand how to use and deploy it. The feedback that we receive across from Africa and across Asia from having spoken to more than 1,000 people is that it's extremely useful, but it's extremely difficult and complex to use. So that's part of the work that we're doing with GOAN and WHO CRO in building this capability. But more than just a one-time training, the idea is to build a community across these countries. Today we have one outbreak. We're likely to have different kinds of outbreaks in the future. So the focus is not just to train and inform individuals, but to build sustainable and resilient organizations or a community of practice that jointly can continue to learn, update, and respond to a particular crisis. And that's what this project is about. And Nepal is obviously as part of WHO CRO. Within the 11 countries, our 5 focus countries are Nepal, Maldives, Bangladesh, Myanmar, and I think it's either Timor-Leste or it's Bhutan was the 5th one. Then USAID has asked us to design and develop content. Actually, it's not 6, but it's almost 13 countries now, all the way from Philippines to Senegal in West Africa. And again, what we've done is to rapidly digitize and develop content targeting various different target groups and make it available. In fact, we recently launched, along with the Ministry of Health of Philippines, WHO, UNICEF, and a few other partners, World Bank as well, the digital learning information on how to respond to COVID effectively. This was almost a month ago. So when we work with different,
Paul?
Yep.
We're running out of time.
Yeah, thank you for that. This is just to say that it's all the different categories that we've targeted, all the different kind of health cadres. I believe it's, and it's not just, as I had mentioned, it's not just outward facing and just training, but also measuring the impact, the reaction, the learning, and did we actually achieve results? And then we have dashboards to measure it, which are then managed by health program managers of the Ministry of Health and the civil society organizations. That's it. Thank you. Back to you.
Perfect. Thank you so much, Paul. And thank you for that overview, which brought in some global perspectives. And now, just to ensure, as I said, before we go into the keynote, we're going to have a poll. So may I have the poll up on the screen, please? And all of you can participate in this poll. So what you can see on your screen are the questions, and you can begin answering them now, because we'd like to involve you, we'd like to engage you. So these are questions that are very general. What is your gender? What is your age? Which geographical region are you from? Which type of organization are you working for? And have you taken any digital learning courses? Have you set up or interested in setting up digital learning courses? So if people can start responding, and we'll see the answers coming in live as people are responding, so we know who's with us, and also where you're from and what your interests are. And these polls not only get the participants involved, but also give us information about how we can improve the webinars and how we can improve both learning and methods of learning. So I would just encourage everybody to vote, participate in the poll. All attendees are now viewing the questions. So we'll give it excellent. Lots of you have finished. We still would like to get up to at least 50%. So please do actively participate. We're up to 46% now, so that's great. We'll try to get up to 50%. Excellent. Okay, so you can see some of the results now. Almost 60% have voted, and I think we can stop the poll now because we don't have that much time. But this was just to make sure that all of you could take part, and that is incredible. We actually have almost 50-50, 49% male and 51% female. That's excellent. We have a lot of young people, and we're very happy to see that. And where the geographical region, let's look. We have, of course, as expected, lots of people from Asia and Southeast Asia, but we have people from Europe, and we also have people from, despite the different time zones, we have people from also joining us, I think, from some people joining us from Africa. Yes, that's right. And then we look at the next question, where people are working, and the academic background, and we see that the academic background is really varied. So it's not only people in health, and it's people from all sectors, which is excellent, which is what this kind of platform is also for, is to bring people from different disciplines together. And the organizations, we have also all organizations represented. We have people from the private sector, from academia, from UN organizations, from some people also working in, sorry, this is moving up too quickly. Some people not working right now, and that is also a result of COVID. And it's also very interesting to see that nearly 77% have taken digital courses, and they have also experience in setting up digital courses in their organization. So that's very good. Did I miss out any questions? No, I think I've been through all of them. So thank you very much for participating. We know also who you are and a little bit of your interest. And if we can stop the poll, please, and continue. That was, appreciate everybody taking the time to answer that. So can we go to the next slide, please? And now for what we often call what you were waiting for, our keynote address. So first of all, it's a great privilege to have the WHO representative to Nepal, Dr. Rajesh Sambhajirao Pandit, who has been recently appointed. And he has long experience. And what is in particular very important for us this webinar is that his experience actually and his work is also with mental health. He knows the region really well. So he is a colleague who knows both the culture, knows the people, knows what are the challenges, but also knows how to address some of them. And he has also been in the Maldives, and he's coming to Nepal from Timor. So without much ado, may I just say what a privilege it is to have you, Dr. Pandit. The floor is yours.
Yes, thank you, Bernadette. And can you see my screen?
Yes.
Okay, thank you. Thank you. Okay, so first of all, good evening and namaste from Nepal, and good morning and good afternoon to colleagues around the world. So first of all, thank you for the opportunity to share Nepal's experience with COVID-19 and for this interesting webinar. I've been asked to talk about what we have learned so far. And I'd like to break this up over the next 15 minutes into 4 whats, which is what is currently going on in Nepal, what's working well, what can be work better, and what's next. So I think previous speakers have highlighted some of the data. I'm not going to go into details into data here, but as of today, the number of cases and deaths have been going up in the last few months, especially after August. And as of today, we have about 237,000 cases with more than 1,500 deaths recorded due to COVID-19. And we are currently in the stage of community transmission in at least some of the provinces, and especially Kathmandu Valley. And these high rates of infection have adversely influenced by three major factors. First was inward migration from neighboring countries, especially in the early stages. And then the accelerator effect of mass gatherings in Nepal, especially during the celebration of major festivals, currently the Dasain and Tihar. And third, the winter in the Himalayan country, leading to more time spent indoors with poor ventilation, factors that facilitate the transmission of COVID-19. There has been a robust all of government and all of society response with support from partners, mounting from an all-out response by health sector in particular. But the scale of the pandemic is now stretching the limited and finite resources. So what's worked well so far? So as I said, strong political support from the highest level of the government and a real efforts toward joined up and collaborative interministerial and partner coordination with regular cluster meetings being organized at national and provincial levels. Then also the health emergency operations centers have been set up in all provinces, and these are being progressively strengthened by being actively engaged in response coordination with continuing enhanced information management, communication and decision support tools and capacity. Then there has been a high priority for risk communication to inform, engage, and empower communities with the right information in a manner which can be easily understood. Nepal has used traditional media and are now increasingly utilizing social media to counter rumors, misinformation, and disinformation as we battle the double scourge of the infodemic and the pandemic simultaneously. Nepal has made special efforts to contextualize messaging for different target groups, for example, travelers, festival goers, and for mass gatherings, and also different language groups, Nepali, Maithili, etc. And what's remarkable is when the pandemic started, Nepal had only one laboratory capable of COVID-19 testing in January, and now we have 77 with both distributed between the public and private sector with a national quality assurance system in place. Also, the Nepal is rapidly escalating surveillance capabilities. There has been aggressive, especially in the earlier part, contact tracing with risk stratified approach to testing, especially effective in the early stages, while efforts were being made to strengthen the health sector response for the imminent surge to follow shortly. So providing high quality and safe care remains a priority apart from escalating COVID-19 related infection prevention and clinical management training for health workers and emergency responders. 20 teaching hospitals and 25 hub hospitals have been strengthened and upgraded to cope with the COVID-19 caseload. Also, health workers and patient safety depends on strict adherence to infection prevention and control standards, and an assessment and upgrade of over a dozen level 2 designated COVID-19 hospitals in Nepal have been conducted, and action plans to address gaps to protect staff and patients were developed and are being implemented. Then, despite the restrictions and disruption to travel and trade, timely forecasting and projections, financial outlay from domestic budget and generous support from development partners have ensured that we have adequate quantities of PPE, supplies, and logistics. As the hospitals and health facilities come under increasing strain, efforts are on to ensure supplies and logistics can be procured in adequate quantity. And what's important is maintaining essential health services is critical to ensure that we avoid subsequent epidemics on top of this pandemic. In this regards, our efforts to ensure immunization coverage has given us the recognition of an exemplar country and is the subject of a study by Emroa University. Despite the ongoing pandemic, Nepal has been currently exceeding monthly immunization targets. Also, similar efforts are on to ensure other essential health services for infectious diseases, non-communicable mother and child services do not suffer. For example, more than 30 of our leading psychiatrists, as was mentioned earlier, are directly contributing to helpline offering mental health support and often overlooked crisis during this global emergency. But we still have a long way to go. So what can work better? There is room for improvement in Nepal's efforts, and top priorities include increasing treatment facilities to manage the increasing number of COVID-19 cases. This means more isolation facilities, this means more HDU facilities, and this means more ICU facilities with trained staff and expertise and logistics to efficiently run these facilities. Also, laboratory testing capacity needs to be expanded further with quality assurance to adequately manage the increasing caseload and test more people. But this must continue to remain a free service if we are to protect access to easy testing. We also need to keep working out more effective strategies to target our communities with correct, timely, and easy to understand information as we deal with misinformation on one hand and pandemic fatigue on the other. We cannot afford to let our guard down at this stage, when in addition to correct information about the disease, right information on vaccines is also needed. And we need to continue to strengthen our health systems to better respond to this and future pandemics. Our best response to health emergencies is a strong and robust public health system with high quality health facilities and adequately trained, motivated health workers, and an adequate supply of medicine and diagnostics, adequate supply of and also high quality health data, adequate funds for the health sector, and good systems for effective partnerships, governance, and leadership. Dr. Tedros, the DG, singled out one country for praise recently for effective handling during this pandemic. This is a country within our region, Thailand, and they have done mainly because they have invested in the health sector over the last 40 years. Health has been a focus of high priority, and the results are showing now. The country is back on its feet and their economy is picking up. This is the best way to protect lives and livelihoods. Money spent on health is an investment for future economic growth. So what next? While we all eagerly await the arrival of a safe and effective vaccine, there have been some recent results which are encouraging. There are still many months away from an adequate number of people who are vaccinated to achieve herd immunity and control the pandemic. Till then, we need to continue to get the basics right over the next several months. That is basically test, treat, trace. All suspected cases must be tested, treated in isolation where their contacts must be traced and quarantined. Test, test, test. We need to build our testing capabilities and laboratory capacity so that we can provide a free test to all those who need it. This will allow us to target our interventions to localized hotspots, including through strategic deployment of antigen-based rapid diagnostics tests, and avoid the disastrous consequences of nationwide lockdowns. And Nepal has recently, in Kathmandu Valley, started a pilot on use of antigen RDTs, rapid testing in the hotspots area of Kathmandu. And then continue expanding the quantity and quality of the quarantine, isolation, and treatment centers, and the expertise of health workers designated to these centers. We also need to get prepared for rapidly vaccinating the health workers, frontline workers, and the most vulnerable population groups, older age and those with comorbidities, as soon as approved vaccine or vaccines are available through the COVAX facility. And also keep striving on maintaining essential health services to ensure we don't have a second crisis on top of the COVID-19 crisis. Not only lives, but livelihoods need to be protected. This has not only been the gravest health crisis in a century, but also the gravest economic crisis. So governments and societies must do everything they can to support their people during these difficult times. But above all, and especially till we have a safe and effective vaccine, our best buy is to get back to basics. So the bravery that this pandemic demands is to wash our hands frequently, to avoid crowded places, to wear a mask, to keep our surroundings ventilated, and to be socially close but physically distant. These interventions sound simple, but they are difficult to adhere to. Pandemic fatigue is setting in, but our success over the next several months will depend on how well we can adjust to this new normal. Thank you.
Thank you so much, Dr. Rajesh. That was a very good overview. And given that you've been in the country a short time, I have to say that you definitely have, in this very short time, understood exactly what the situation is in Nepal. And what is good is, while we all know the problems, and the problems are often what everybody focuses on, it's very good to look to the solutions. And I think your messages, take-home messages at the end, are so important in looking forward and trying to take the message of hope with us. So thank you very much with us. Thank you very much for that. And I hope you will stay with us for the Q&A at the end. We're running a little bit late, so I'm going to hand over very quickly to Dr. Saroj and to Dr. Saroj and to Dr. Suraj. If we can go to the next slide. Yes. So that we start the panel number 2. Dr. Saroj, if you can take over as the chair for this session, along with Dr. Suraj. Thank you.
Thank you very much, Bernadette, for your giving me opportunity. Now we are moving the another panel discussions, mental health and culture. Mental health is not clearly the matters, policy matters for the politicians, or the clinical matters for the clinicians. I think it is emerging as a key social issues that affect a huge number of individuals and their families, especially after COVID pandemic. Whereas in other hands, culture is one of the fundamental ways in which the people shape their world in a unique patterns. Every culture has got their own backgrounds, cultural norms, values, and the bias. Some of the culture, they absorb negative emotions, without expressing their disturbance, or without mentally unstable. So their resilience is a very important part. So today we are going to discuss in the second panel discussions, Dr. Suraj Thapa from Oslo University. He is also with us. And we have 3 key speakers. May I introduce our speakers? There are 3 speakers: Professor Lawrence from McGill University, Professor Jaswant from also McGill University, and Maria Leonhardt in Landed Hospital Trust, the 3 speakers. And first, I would like to introduce the Professor Lawrence Kirmayer. He's the professor. He's also the editor-in-chief, Transcultural Psychiatry, and director of the Culture and Mental Health Research Unit at the Institute of Community and Family Psychiatry. He is a fellow of Canadian Academy and Health Sciences and of the Royal Society of Canada. Professor Lawrence, because without wasting time, may I request Professor Lawrence for your keynote speech on mental health and culture. Professor Lawrence.
Thank you very much, Professor Saroj. I'm going to share my screen. Can you tell me if you see my screen okay now?
Yes, we see you.
Yes, yes.
Great. Okay, thank you. Well, it's a great privilege to be able to join you here in this virtual way. That's a great leveler. We're connected all over the world. This is one of the few, I think, positive things about being stuck in confinement and having to use Zoom all the time. I guess I also feel that this is not only virtual, but it's virtuous in some ways, in the sense that at least we're not flying around the world contributing to climate change. So we'll take our blessings where we can find them. I'm going to talk for a few minutes about the mental health dimensions of the COVID pandemic and the intersection between mental health and culture and context, which is a major concern of our program, and the kinds of research and teaching and practical applications that we try to look at. So what I'm going to touch on very briefly, and you'll have access to these slides afterward and other resources if you want to go into more depth, is the important role of culture and context in global mental health in general, and some of the contexts of the COVID epidemic that vary in some ways and that need to be taken into consideration when we're looking at mental health impact and responses to that. And I'll focus in then on how culture makes a difference and ways in which we can think about mobilizing culture and community resilience to help us address the challenges of the pandemic. So this has been a major focus of our previous conferences. We've emphasized spirituality and religion as one dimension of people's cultural traditions and institutions, but of course there are many different facets. And the challenge for global mental health and for sharing knowledge across different regions is because we are cultural beings, because our experience is very much shaped by the way that we're brought up and the kinds of environments we live in, we need to think carefully about the generalizability of certain practices and not overlook the potential to use existing ways of coping with challenges, with stresses, and mobilize those in effective ways when we're facing a crisis like the COVID pandemic. One of the striking things about the COVID pandemic is that at the moment, there are a number of high-income countries with lots of resources like Canada that are having a particularly bad time dealing with this. And that in itself is instructive. It may have to do with urbanization. It has to do with attitudes toward response to public health messages, but it raises very interesting questions about the kinds of challenges we're facing. Just for comparison here, Nepal has a population, I think, of around 28 million, and Canada has 38 million. So it's they're not that different, and you can see a big difference right now. We're in the midst of a second wave. We had the highest number of cases yesterday here in Quebec, and I'm sitting at home since February, basically working from home. So this points to this whole issue of the context of COVID. We want to think about the setting that we're in, and when we get advice or ideas or approaches that come from international organizations, from WHO or from countries of the global West or North, we want to be able to think carefully about how well they do or do not fit local contexts. And that includes issues of geography and the physical environment, of the demography, the composition of society, including its diversity and its social structure, the levels of infrastructure, and in particular, those aspects of infrastructure right now that are related to the internet, to telecommunications, because this is a major tool that we have, and we're facing this pandemic in a very different way than past pandemics, in part not only because of scientific knowledge and our ability to mount a quick response, but also specifically because of electronic telecommunication and the way that that's enabling e-health and maintaining social networks in ways that are otherwise challenged. We need to look at the nature of the local healthcare systems. We've heard quite a bit about that already today from the institutions and experts in Nepal, and the attitudes toward expert knowledge, because this is a situation, as we'll talk about, that is characterized by high levels of uncertainty, and the level of trust and confidence, or the ability to tolerate uncertainty in the population, is important. And so this exacerbates issues of mistrust. You've seen how highly politicized the whole public health effort in the United States has become, to their great detriment. And we've also seen dynamics in many places, including here in Canada, where the virus has been identified with people of Asian origin, and people have experienced racism and discrimination on the streets as a result of that kind of misunderstanding and in-group, out-group dynamics. Finally, important part of the context of the virus is looking at the temporal dynamics, the ways in which we are facing either a brief wave or repeated waves, or a long-term wait until there'll be vaccines and extensive immunity and so on. So that our ability to tolerate a crisis is very much shaped by the temporality of it. Is it a short-term thing that we can all rally for, or is it going to be a long haul and poses special demands? In the case of the pandemic, it's not only the threat of the virus or the actual impact of people getting sick and both the acute threat and whatever long-term effects there may be from having been through infection, but there are also major effects from all of the efforts that are ongoing to mitigate the impact of the pandemic, the changes in the economy, huge challenges in that respect. Burdens on families and domestic care with children being homeschooled and so on. I've already mentioned this problem of high levels of uncertainty, changes in people's social networks and social environment, and spending huge amounts of time glued to the screen watching various things. And then in every society that we know of right now where we have data, we know that there are huge disparities within the society in terms of who is most affected, both by the pandemic and by the mitigation efforts. And so this is a kind of intersectionality, and vulnerable groups are experiencing the worst effects for a whole variety of reasons. I won't belabor the data. It's constantly coming in. There's an enormous number of studies, as already mentioned, but we have lots of evidence now of a large mental health impact of the pandemic, in particular with high levels of anxiety and depression and so on as a result of all of these impacts I've been mentioning. Mental health workers or health workers in general, I should say, are at significant risk for some of these negative effects because they are really bearing the brunt of responding to the pandemic and seeing some of its most devastating effects on a regular basis. So any plan, any approach that we have to deal with the mental health effects of the pandemic needs to be considering health workers as well as those most vulnerable. The kinds of symptoms that people are seeing are in general the most common symptoms of stress and distress that you see across different settings. But as Dr. Oja just pointed out, these are expressed in different ways in different cultures and contexts, and maybe expressed in terms of physical distress or local idioms, cultural idioms of distress that practitioners need to be aware of. We're starting to accumulate some evidence on what are the risk factors for mental health consequences. Obviously, people with a pre-existing mental health problem of some kind are going to be at greater risk in general, but also people who are having a lot of stresses in their local social roles, taking care of children, taking care of a household, being confined in a situation that might lead to stress within the family and so on. So you can see a whole variety of things here that can contribute to greater vulnerability. These are going to vary across contexts, but I think many of these will be similar for people in different places. The overriding considerations, of course, are economic and just basic issues of sustenance when local infrastructure is disrupted, as it has been in many places. These are the kinds of concerns in a survey in Canada, actually, that people expressed at the beginning, and most concerns about the family and about getting adequate care, some concerns about food insecurity, and there are places in the world where that is a major issue right now for people. I mentioned the temporality, the fact that all these concerns are occurring on a particular time frame, and I think that's important because we can all tolerate quite a lot of challenge if we know it's going to be short-lived. And what's happening with the pandemic, of course, is that the initial wave of people getting infected is being followed by subsequent waves, and that will continue for some time. We're in the second wave right now here in Quebec and North America in general, but there will be further waves as things go on. So that challenges people's sense of hopefulness and their sense of being able to endure. So we need to think in those terms of all the factors that are impacting on people. Here's a slide that just sort of summarizes some of the factors that I've been talking about. And these are very important because mental health is not just about particular psychological processes that people are having or particular vulnerabilities, but also very much about the social context that people are in and the kinds of messages, the kinds of explanations, the kinds of responses among themselves that they can mobilize. So let me just go here. There's quite a lot of evidence. Here's from a survey done a while back by WHO showing that in most places there's been quite a bit of disruption of mental health services, that it's very hard to provide services if there's confinement, if health workers are at risk and so on, if people are afraid to come to facilities. And so there are a variety of strategies that people are exploring using telehealth, using various kinds of networking to try to provide basic services and support for people. I just have a couple more slides. So although we might focus in on the effects of anxiety and uncertainty and view the whole situation as kind of very stressful, even traumatic for people, we need to recognize that a disruption of everyday life that's occurring on the scale that it can occur with the pandemic has effects in many areas of people's lives. So this is a table based on the work, or from the work of Derek Sylov in Australia, who's looked a lot at the impact of torture and massive human rights violations on health and well-being, and to make the point that this is not just about post-traumatic stress disorder or stress-related problems, but many other domains of life. And I think we can usefully use this kind of a list of dimensions to think about the context of COVID, to recognize that people are also being affected by loss of loved ones and family members, by issues of the unequal distribution of resources in a sense of injustice. You know, the fact that in many countries there may be delays in people getting access to vaccines or other kinds of life-saving and protective interventions, that everyday work and activities may be disrupted in ways that undermine people's sense of resilience, and that the magnitude of the problem may pose really existential questions for people about how things work. How does culture make a difference in all of this? How we explain health problems, including infectious diseases, varies based on our knowledge and our models. It's not simply a question of having the right picture and the wrong picture. We all bring different kinds of frameworks to bear to figure out, well, why did I get sick and this other person didn't? And we use those. And so often people have explanations that involve moral dimensions, spiritual dimensions, social dimensions that are an important part of their explanation and can become a part of their suffering or a part of their way of coping and dealing with things. That extends, those different cultural meanings extends to the whole issue of responding to the mitigation efforts, wearing masks. Again, you've seen a very striking cultural example in the United States, where people are objecting to wearing masks because they view it as a challenge to their civil liberties, which is for many other parts in the world, including in Canada, a somewhat odd response, and highlights sort of a particular culture. So we need to think about that in every context, in the context of Nepal, again, what the significance is of these public health strategies and how people respond to them. The changes in domestic space, people are thrown together. When they're thrown together in confinement, it can become a bit of a pressure cooker in the family, and if there are pre-existing marital conflicts, for example, then people are at greater risk for domestic violence and so on in response to the mitigation efforts, not just the virus itself. Overall, there's a whole challenge of how we deal with uncertainty, and in relation to that, how we respond to medical authority or government authority when we get a public health warning or advice and so on. Does that instill confidence and comfort, or does it raise other concerns about what's going on and so on? And the ways that decisions themselves are being made, the priorities that are being set in a particular society for delivering services and so on, also reflect local culture as well as local politics. So all of this then has implications for how we can respond. This is my last slide, how we can respond to the pandemic. Not just by viewing cultural differences as a barrier or as a side issue, but really understanding how, by engaging with understanding the local context in all of its facets, which include the cultural meaning systems and practices that people have, we can mobilize resources that will be helpful for people. Culture in the sense of the way that people live, the religion, the language, the family networks, and so on, everything that people have that make up our lives is the main source of resilience and resources we have for coping with challenges. So we need to recognize, first of all, that existing disparities between haves and have-nots in particular societies are being aggravated by the pandemic. And people are differentially affected, that we're in a situation that's not just about an acute emergency, but is really going to be a long haul. And this is not the first also, or the last pandemic that we're going to face. So we need to be thinking ahead in terms of how we're going to deal with this. Being able to provide people with very clear information from a reliable and respective source in language that makes sense to people is vital to all public health messaging. So it has to be done in a collaborative way, thinking through what the meaning is of particular messages for different segments of society. People need support when things are disrupted, when their livelihood is disrupted, or when when they're experiencing loss of life and loved ones and so on. There are various kinds of support that need to be mobilized, and people need to be assisted in their own self-care and mental health promotion through whatever kinds of vehicles are available. We're working with Indigenous communities in Canada, some of whom live in very small remote communities, and trying to use telehealth and activities that youth can use to sort of engage in ways that are constructive and that bolster their mental health. And we need to be looking at all the kinds of resources we can use to maintain connections among people and a sense of meaning, of working together, moving ahead, and with a sense of hope and solidarity. So that's just a very broad and general summary. I hope we can have some discussion about the specific ways in which this applies to the context of Nepal as we go forward. So thank you all very much. I'm very glad, as I said, to be able to take part in this discussion.
Okay, maybe I can. Dr. Sarosh, are you there?
I know he had logged back in, Suraj. So
okay, so maybe I can overtake. It's okay. Thank you so much. Thank you very much, Professor Lawrence Kirma. It's always nice to listen to you. And then you already covered both the mental health aspects of COVID-19 and also focus mostly on the cultural part of related with this pandemic. And then you brightly pointed out about the coping strategies and then different factors and also different aspect of that part. So I think we'll come back to you. And you have already received a few questions in your chat box. So I think we'll move forward and then we'll come back to the discussion. Now it's a great honor to introduce another speaker, Professor Jaswant Guzdar. I know that you've been awake since 3 a.m. in Western Coast of Canada. I'm very sorry about it. But I'm very happy that you could join this webinar, and then it has already been nice to have you in Kathmandu in the past few years. And Jaswant is a professor at the Department of Psychiatry at the McGill University, and then you are also trained as child and adolescent psychiatry. You've also contributed, to some extent in establishing child and psychiatry department in Kathmandu when you've been in Kathmandu and afterwards. So the floor is yours, Jaswant.
Good morning. I sent 2 slides to you because I'm not really emphasizing slides. I sent them to read. There it is. Thank you for having me. And I'm sorry that we are missed being with you in real time in Kathmandu. I'm going to be talking mainly about children, and I want to first of all thank Dr. Oja and Dr. Thapa for all the amazing work they've done in bringing Norway and Nepal together and with us at McGill. It's really a great honor to watch the escalation of child services in Nepal really since 2015 when the earthquake struck and Arun Kanwar moved in to be the first child psychiatrist in Nepal, and really with CWIN has really started a whole process in the last 5 years to meet the onslaught of COVID. And I'm going to begin by reading a short summary that was sent to me by Arun's team, by Gunjan Donjan, because it's very important for us to be on the ground with you, and we are only able to do that through this wonderful technology and exchange ideas. So they are reporting right now on school closure and lockdown, isolation and quarantine, which has resulted in restrictions for children and youth and from all of their usual routines, which we know are very important in development and in mental health and self-care, as Lawrence and other people have just stated. Now, many children have presented in Nepal with fears of infection, of dying, and of worries related to losing family members and who might fall sick from COVID. The common symptoms that have been seen in the child and adolescent psychiatry and mental health referrals, and especially in the OPD, are stress-related anxiety symptoms with physical manifestations and somatic symptoms. That is pain, palpitation, shortness of breath. And the emotional dimension is mainly sadness, fear, anxiety. The behavioral changes include things like increasing oppositional behaviors, in tantrums, and very often for youth, and we see that here too, a retreat into video and online dimensions, which form some kind of haven. We have taken COVID in Nepal, the team says, as a stress factor affecting mental health of children and adolescents across the country, with travel restrictions resulting in very poor access capacity of the team. To overcome this, the team has developed a manual for sessions on COVID relating stress identification and management, focused on children and adolescents, teachers, parents, and caretakers, which is our usual strategy in child work. We want to strengthen the caretaker. These sessions are conducted online via platforms such as Zoom. We've conducted around 1,500 sessions with reach of around 30,000 individuals. Half of these have been child and adolescent populations directly. They've reached a population of all 7 provinces in Nepal, and this is being conducted with the support of UNICEF, which commenced this project in July of 6, and is going to continue to be funded until February 2021. So this was the most recent update I had from Arun Kanwar's team. What we have been dealing with then is talking about children and the social disadvantage that COVID has unmasked, as Lawrence and others have mentioned, and how were we ready and how were we not, what kind of things we're learning from COVID. And there are a number of dimensions of this that are very important. One of them is that Nepal was rather ready in some ways with the coming of Arun Kanwar and Siwan to begin the infrastructure building, because already by 2019, the Kanti Hospital unit, which Arun established with his small team, had seen 3,300 patients in that clinic. And they had also begun to do the training of child psychiatrists, and 2 of them have already graduated with the input of Bangalore and Nimhan's and Shekhar Shashadri's group there. And so this has, the plan is to increase the manpower of child psychiatry and of child professionals. And this has increased a very important part of the infrastructure of community response. Now, Dr. Kanwar and his team in 2015, when the Nepal earthquake came, began to look at all of these consequences of an epidemic. And his team had already trained a lot of his people through video conferencing. So the core team had already reached out to 10,000 children and adolescents through that initiative. Dr. Kanwar's advocacy also, and this is very important in terms of what we've been talking about the impact on children of safety, because if there are already issues in the family, or there are migration of fathers, or there's absence of caretakers, or somebody gets ill, the increases of stress are very high. And so we also have worries about protection. We have worried about how we are going to be able to care for children. And this has become a really important issue that is just beginning to be scaffolded in Nepal. And the best way to address that is connection. So if the children are in school, or we have access to the parents. But in COVID, we have these very unusual circumstances of isolation and of not being able to connect, which is so important for mental health and for protecting parents and for decreasing and de-escalating negative affective states and addressing this. So we have that to look at. We have also to learn from COVID as it marches forward in this experience, that all these other projects of child mental health, including protection, we're still learning how to deal with that. Dr. Sheshadri's group in India is looking at training the judiciary, and Arun Ganwar's group in Nepal is also very interested in assisting juvenile justice courts and all of the caretaking facilities in Nepal to look at for example, they have a study right now on mental health status of children residing in a child correctional home, so that all of these other kinds of vulnerable populations are part of our COVID picture and of what we're going to be looking at. The other thing I would say as a clinician, and right now I am on the Pacific Coast since COVID, and I'm working with indigenous communities and refugees out here. Similarly to your situation in Nepal, where people are isolated, as we've all said, we're all limited to Zoom, and Zoom assessment of children is quite challenging. So I am assessing children now who are really becoming very anxious and very depressed, but their families are also collapsing on the basis of cumulative trauma that happened well before COVID. So what we've understood is that if there's pre-morbid conditions around families and communities that make them vulnerable, COVID is really stretching our imagination to look at what ways we scaffold these families. How do we support people in isolation, and especially children, because they have no advocates. So now we're talking much more about allyship, about strengthening advocacy, about participating together in looking at young caretakers who have to look after people who are ill, the positioning of youth who are facing great uncertainties at this time and their educations are being interrupted, and so on. So these are going to be aftermaths of COVID that we really don't know about yet. It's almost like a tear that in our narrative. Now, children relate to narrative tears very well through storytelling or through participatory play or through group process and through those kind of solidarities. And COVID has really limited the usual ways that we would scaffold and strengthen children. This is quite a challenge for us in child work. And I no doubt it's going to be an ongoing input from Nepal. Now, what Nepal also did, where there were studies, Dr. Sapkota and other people have done studies in Nepal on the impact of the war, for example, the civil war on children, and how much more there was of dissociative disorder, vulnerability, that may have cultural roots as well as collective roots, and it's a very complex agenda of thousands of years of cultural stories. How do we tell stories about why bad things happen to good people? And these are the stories that children relate to, and how do we change those narratives or introduce other kinds of narratives? And this may be part of what the outreach has been about, the psychoeducational output, but it is also about the creativity of this time in our work with children, because really it is an action research experience to treat children with who are going through this experience of isolation. And it is very challenging. I am finding it very challenging here clinically with children who have had years of cumulative trauma in the indigenous communities, and how to establish trust and to outreach to these children has become quite a difficult agenda. And I know in Nepal it is very difficult because the distances are so vast and the infrastructure is fragile, although it is being built. So I am very much interested and looking forward to the input of experience on the ground in Nepal to record at this time what our children are feeling and what are the mutative and positive things that we can do to help the narrative of children and support them through this kind of process. And I think we are certainly know that trafficking and the health of women and the vulnerability of women at this time, and the absence of migrant workers and maybe the loss of income to remote areas whose older people might be out trying to found work in other countries and who might be in very great difficulties at this time. So there are many kind of cascading issues which are very particular to a country like Nepal, which for centuries has had migration of people back and forth. But right now, in this time, and we saw this terrible crisis in India with the migrant workers, almost they're subalterns in terms of receiving services and having outreach, and how the kind of resonance. And child trafficking, of course, we've always had tremendous social challenges in Nepal about how we're going to handle this. I'd really very interested in what the audience would have to say about this as well, and what people on the ground in Nepal itself are experiencing with children and the challenges that they might be having in the outreach with technology. So those are my limited responses, and I hope they might be of interest to our group. Thank you very much.
Thank you very much, Jaswant, for your very good overview of children's mental problems, and then with the special focus in Nepal. And you rightly said that like the issues related with the migrants will be a huge issue, and has always been a big issue in Nepal as well, because Nepal has sent about I think I don't know, actually 8 million people or something like that, at least over 5 million people to different parts of the world as migrant workers, and then many of them are in Middle East, and then quite big numbers are in Malaysia and Southeast Asia, and many more in North America. So that has also been a big discussion during the COVID pandemic. Now I would like to proceed further, and our last speaker of this second session is Maria Leonhardt. Maria has a master's degree in public health, and then you have also a doctoral degree from Germany, and then you've been very much interested in immigrant mental health, behavioral epidemiology, and you've been also in my research group, and we have met a couple of times. It's really a great honor to have you today, Maria. So the floor is yours.
Yes, thank you for giving the opportunity to share the first results of our study, the impact of COVID-19 outbreak on persons with concurrent mental health and substance use disorders. Next slide, please. Yeah, so why such a study? If everyday life becomes difficult due to a pandemic outbreak for persons with economic and cultural capital, it becomes even worse for vulnerable groups such as persons with mental health and substance use disorders. They are often subjected to social exclusion and are very dependent on a functioning social and healthcare services. The statistics from the Norwegian Service User Plan have identified approximately 26,000 persons with addiction and mental health problems, and they have low levels of functioning in important areas of life, such as poor living conditions, financial and social problems, and they are often weak integrated in their communities. As a consequence of infection prevention measures, which are implemented at population level, low threshold measures for persons with mental health and substance use disorders, such as syringe services, public meeting points, or soup kitchens, have been closed in Norway. And many patients with mental health and substance use disorders admitted to long-term inpatient care were being discharged. And as the pre-existing mental health and substance use disorders are likely to worsen in the face of fear and distress, such in a pandemic outbreak, lockdowns imply an even greater burden for persons with mental health and substance use disorders. And what's more, the virus attacks the lungs, and people who smoke or inhale drugs are at particular risks. Yeah, so therefore, our study focused on the social dimension of the pandemic. And this our aims to explore and the experience and actions of persons with mental health and substance use disorder, and secondly, describe the incidence and causes among this group, and third, to explore the utilization of healthcare services. Next slide, please. Next, yeah, thank you. We apply a mixed methods approach, conducting qualitative and quantitative studies. We aim to recruit 25 persons with mental health and substance use disorders in the qualitative study, conducting individual interviews and focus groups. In the entire research process, we involve peer support workers, which are persons who live with mental health and substance use disorders. The quantitative study is a register study. We'll start with this in January. So right now, in this presentation, I will focus on the qualitative study. Next slide, please. The results are very preliminary because we're still in the process of analysis. So how did we proceed? First of all, we established a reference group with peer support workers. Some of the peer support workers have an education as a peer support researcher. Together with them, we designed a semi-structured interview guide and recruited participants for the interviews via the municipal mental health and addiction services. We conducted 17 individual interviews and just one focus group because the participants could choose whether they want to participate in a focus group interview or rather in an individual interview. We use thematic content analyzers, and also in the analyze process, we involve our reference group. Next slide, please. Yeah, this is a short overview of our study population. 15 men and 7 women with mental health and substance users did we talk to, quite wide age range, 24 till 65 years old, and most of them took amphetamine or heroin, but also alcohol and cannabis. 6 participants were in a medical assisted treatment and got methadone or Subutex, and 3 said that they are clean. Anxiety and depression, HDHS and PTSD were the most common mental health problems they reported about. Many reported that they have somatic problems as a COPD. Next slide, please. Yeah, this is the preliminary results. Nearly every of the participants said they were afraid to infect others. I don't want to infect others, especially older people are much more vulnerable than me. But they were also quite worried about losing their social network. Finally, I have a social network. Now is everything crashing. Or I should have died instead of many others who have died. I'm just an old junkie. There's a fear I have not seen before in this country. So hopelessness was also a thing which are very concerned, but also getting a relapse. I was clean before Corona. I'm afraid becoming addicted again. Everything is so hopeless. But everybody we talked to was not at all concerned about getting COVID themselves. Next slide. could you go further? Oh no, back again, please. And back again, because there's something missing. Oh yeah, okay, but there's a second column which we don't see on the slide, but there were also some challenges. So they describe that they were missing physical contact. I miss embracing and or touching somebody. But also there was a decline in mental health. I'm just hanging around, getting more and more depressive. And they were reporting about us feeling socially excluded and stigmatized. So if you are a drug addict, people take special distance of you in these times of COVID-19. Next slide, please. No, back please again. Yes, thank you. So how do they cope? How do they act in times of Corona? So self-quarantine was mentioned. I locked myself in, locked the doors and windows, waiting until all is over. It's good to know that everybody is in the same situation. That helps a lot. But also acceptance and resignation. There's nothing we can do, we just have to accept. And some were quite ignorant. They said, I don't care about Corona, just live my life. But also a higher consumption of drugs was mentioned quite often. I'm drinking until I don't feel anything anymore. Or I then began experimenting with heroin again. Yeah, but beside all these negative impacts, they reported also something positive. So they said, social distance makes me taking less drugs. I meet nobody, I consume little. And they said that they learned to be endurance, patience, and they learned to be more tolerant. So I really appreciate that they deliver the methadone on my doorstep. The nurses are doing a great job. I have full understanding for the Corona measures. I learned enjoying my own company. So summing up, persons with mental health and substance use disorders are also facing big challenges in time of this pandemic. And the pandemic worsens already existing problems. So persons with mental health and substance use disorders are dependent on functioning health and social services. So maintaining low threshold services is very important. Now the society in September was opening up again, and that was the time when we conducted these interviews. And they said it's great that we get some support now. Thank you very much.
Thank you, Maria, for your wonderful presentation from your qualitative part of the study, and then and also for finishing in time, because we all know that we've been running a little bit of time, but then since it's been a wonderful presentation from all the presenters, I hope that you don't mind if we have 15 minutes to discussions. And then I would like to invite both the first panel and the second panel. I can start putting and then I have seen that Lawrence has already replied to many of the comments and the questions to you. But then maybe I can start with a small question to Maria, and then maybe others can also reply. If you have an experience, because in our hospital we've been discussing almost every day that we don't see, or we don't see COVID. I mean the drug addicts or the people having the substance abuses and addiction problems have been seen there has been reports of having lower prevalence of COVID-19 among this kind of populations, even though Lawrence was mentioning earlier that we have to think about the vulnerable populations, like the people who have poor background, low education, women, or even the people who have drug addiction and other problems. But then observation in the hospital is that these special population, like maybe they are more resistant or like more like resilient. They have more resilience against COVID-19. Do you have any comments or any literature about it, Maria and any other colleagues?
That was basically what most of them reported. We also asked them, why do you think that there are so little infections among drug addicts? And they said by themselves, well, there's so many, we are so polluted that COVID-19 and that we don't get it. But also they mentioned that they take all the infection prevention measures very, very seriously, because they are already very stigmatized. So if they don't use and wash their hands and take masks, they would feel even more stigmatized.
Thank you, Maria. Any other comments? Otherwise, I want to move to the other issue of like this culture and mental health and COVID-19. Probably some of you or many of you have read the editorial published in British Journal of Psychiatry by we and colleagues, where the title was, is the COVID-19 virus racist? Because we've been seeing that it's been affecting badly the people with immigrant backgrounds, and that we see even in Norway. Even though, as I presented in my presentation, that there is a relatively very lower rates of COVID-19 in Nepal, but then in Oslo we see that the positive cases are more among the people with immigrant backgrounds, and then we've seen a huge difference in England, in USA, even in Canada, and so on. So, and when you talk about the culture, then the other issue, maybe the colleagues from Nepal can also comment on it, because there are so many different cultural aspects associated with the COVID, and also related with the deaths, and the beliefs about this COVID-19 and so on. So culture is really plays really important role in this pandemic. And then even in Nepal, I think I heard that people were not allowed to attend the funerals, and then it was the army or even the soldiers were given the responsibility to carry out the funerals. That will definitely have a big impact on people who believe in Hinduism and Buddhism, and many the rituals and traditional activities have been stopped and so on. So maybe any comment on it, Lawrence or Jaswant or any other colleagues or Dr. Rajesh and so on about
I'll respond just briefly and to the 3 points that you raised, or one is the differential vulnerability of different groups, and it's certainly the case in the UK, in Britain, in Canada, that people of color, which is a category that gets created when you migrate from one place to another. Suddenly certain people are visibly different and are marked out. And that's not just a neutral fact, it has consequences. It's associated with systemic racism. It's associated with different challenges that people face in their everyday life. And those are major social determinants of health. They affect every aspect of health, mental health, as well as many common illnesses. And there's already pretty good evidence that that is playing out dramatically in the case of the COVID epidemic, and who gets sick and who gets the most severe cases, and then who may have the worst outcomes, not only because of the case they get, but because of limited access to healthcare, because that's another aggravating structural factor that then happens for people who are poor or who are not well connected, and and so on. So that's a major concern, and we don't know it in every place because people don't necessarily collect this data in every place. Even here in Canada, it's been hard to convince the authorities that they should be collecting data on people's background, their cultural or ethno-racial background, simply because that is going to intersect with vulnerability, and we need to be addressing it and understanding why. Why that happens, I think, is complicated again. It has to do with physical circumstances. People may be living in crowded housing. One of the ironic aspects for us is many newcomers, people from the Caribbean, people from other places, actually work in healthcare. They work as orderlies in hospitals and other places, and so or nurses and others, and so they've actually been on the front line. And I say it's ironic because these are people who are actually taking care of other people in the mainstream society and putting themselves at risk, and then bearing an unequal burden of the consequences. So it's a very poignant thing. It's an important message to get out because it counteracts some of the racism and discrimination, to realize that this group that is being more affected, it's not because of their vulnerability necessarily, but it's actually because of the extra contribution they're making to society in terms of helping people. So that's a positive message to kind of help to mitigate it. And then you mentioned two other things. One is how people cope then with the situation, what kinds of resources they have in terms of extended family to deal with all the challenges of having children at home or and having worries and so on. And then what happens when people do get sick or when they face the loss of a loved one and how disruptive that is. One of the areas that's been hardest hit here is old age homes for people who are who have health problems. So people are in these facilities that are have had very uneven quality, and there've been a series of epidemics within those care facilities. With large numbers of elderly people dying. And aside from the injustice of that, of not taking proper care of our elders in our society, it's hugely painful for people because they can't be present, they can't be with their loved ones when they die or afterward and so on. So it's causing a lot of grief, a lot of complicated grief for people around that. So these are some of the maybe secondary effects of the situation, and some of them are going to be important carrying forward. I mean, this concern, as Jaswant was talking about, in terms of the developmental effects on children right now, having their schooling disrupted, children who maybe really need social contact and so on, who are not getting the kind of early experience they need, but equally for adults and elders in terms of quality of life. So I think all these need creative solutions and to be talked about very directly within communities.
Thank you, Lawrence. Any more comments? And lastly, have you got access to ask, because you want to ask a question, right?
Yes, please. Thank you very much. And thank you very much for this webinar. Very nice to be here today. And I really enjoy all the speeches, and it's been very great to listen to. I just have a question actually to perhaps some of the people working with mental health in Nepal. There's been some what should I say, some findings or disturbing news about especially the situation of women during the COVID-19 epidemic. Could you say something about that? It seemed to be that women are especially vulnerable because of the lockdown and family disruptions due to the COVID-19. Could be nice to hear more about these rumors that have been going around some places. Thank you.
Dr. Saroj.
Okay, thank you very much. Yes, thank you for your questions. Especially during the lockdown periods, the people, as you know, the society, Nepalese society, we have our own culture, and the people are inside the home, and especially the people who are working outside, they are locked down in the home, and because of that, the increased use of alcohol, increased use of substance use, or increased use of tobacco, because they are people are there, plenty of time, and they are busy with the internet and social media. So because of that, the women's especially, they have the huge responsibility looking after their family members, looking after their day-to-day activities. So because of that, I think the people, especially females, they were some kind of the anxiety, the symptoms, depressive symptoms. They have suffered from anxiety, depressive symptoms, and some of them are getting abused from the family members, or even from the, because of the many people are financial problem. People are in the financial problems. So the reason because of that, the females, women's are having many anxiety and depressive symptoms. That's my comments.
Can you say something about whether you think that things will change because of the awareness that in fact women are far more vulnerable in this society? And what the issue is, will COVID help us to address disadvantage? I guess that's my question. Is it, you know what? Thank you.
Yeah, especially after COVID, you know, in many people are having mental health problems. There are a tremendous awareness among the people because they have understood that they are having anxiety, they are having sleep problems. So the people are getting aware about mental health problems, and especially because of this COVID-19, even the governments, the media, the social media, the newspaper, they are bringing a lot of awareness, mental health awareness. So this is one where we have received, you know, the opportunity to bring the positive awareness among the people, and not only from the general people. You know, I have also in my one of the presentations that the Nepal government's Prime Minister asked us to do something psychosocial support for the general people, especially those people who are having the COVID fear, living with the COVID fear. So the psychiatrists, the psychologists, or the health ministry should look after these people. So I think there are tremendous awareness among the policymaker, among the general people. So this is something we are getting some kind of the good opportunity in the area of mental health.
Thank you, Dr. Saroj. Now I would like to invite Bernadette, because you have a question to Dr. Peters, and then maybe it's also time to sum up and then close the session. Bernadette, unless you have any other. Please.
Yeah, thank you, Suraj. I think that it's been a very, very active chat. There were a couple of questions that were directed to Dr. Biraj. So Biraj, this is your opportunity to respond to them. Are you there, Biraj? Okay, he's, I don't know, co-host. I would just, while we are waiting for Dr. Biraj, maybe ask the two keynote speakers very quickly to have a short summary take-home message. So if I could ask Dr. Rajesh first, and then Dr. Lawrence, to just give us the take-home messages from today. Dr. Rajesh?
Yeah. Sorry. Yeah, thank you. Thank you for a very informative session, and from also discussing various mental health issues on this. So as we wait for, I saw one question on vaccines. So there is now hope that there will be some vaccines, but this has to be supplemented with public health measures, because the vaccines will not be available from the entire population in a very short period of time, and especially as WHO is working with in terms of the COVAX facility to have the vaccine for 20% of the population. So it's imperative that we need to follow the public health measures, and basically the measures which I have highlighted, basically to do case investigation, contact tracing, testing, ensure people are identified and people are empowered and communities are engaged to follow the basic public health precautions that have been highlighted. So there is no escape from that. So these measures need to continue as we wait for the vaccine. So I think that's one message. And regarding mental health, people are also losing their livelihood. So that's also causing a burden on them in terms of mental health issues. So how governments can intervene in this to see how people can have opportunities to improve their livelihoods. Also, where especially where people are told to stay in quarantine, and those who are living on daily wages, those social support systems need to be provided to them so that they can follow the isolation and quarantine measures. I think these are the 3 points I would like to highlight. Over.
Thank you so much for that. And very important. As you can see, it's not possible for us to applaud, so I'm here applauding for everybody. Um, and Professor Lawrence, I think one of the important things is this is not going to go away tomorrow, so we have to live with this. So could you, give us some coping strategies, and what would you advise? There's a lot of health professionals, a lot of academics. So if you could just, take some take-home messages about that. Thank you.
Thank you. Well, we know the ingredients of well-being for human beings are first and foremost relationships with other people, solid relationships with other people. So if those are being disrupted in any way, whether it's because of confinement or anxieties or other kinds of things, we need to be addressing that directly and maintaining and rebuilding those kinds of relationships. That speaks directly to the issue that was raised already about the predicament of women in homes who have multiple responsibilities and burdens and who may not have mobility, especially at a time of confinement, but even under other circumstances, to be able to reach out for help and get support. So I think that needs to be looked at very carefully in terms of the predicament of women in the home. And then the needs for well-being and the shape that takes differ across the lifespan in terms, for children and for youth and for adults and for elders. So it needs to be considered. Those are all connected in important ways, but the specific needs are different. But what they all share, as I say, are meaningful relationships, supports, and meaningful activity. In other words, if one can keep engaged in some way in something, despite having disruptions, let's say, of one's everyday work or schooling or whatever, then you will not suffer from the kind of hopelessness and despair that comes from being just uprooted in your life because of the large-scale disruption. The other challenge in this, and it's a new challenge, is for many people, is dealing with the high level of uncertainty, even from within medicine. A lot of the comments in the chat were also about this dilemma that there are, in many cases, no absolutely clear answers, and people in public health and other authorities are weighing imponderables. How much do we open up? How much do we close down? It's not 100% clear. Nobody really has an absolutely clear map, and that creates uncertainty. So I think there's a whole new challenge for people in learning how to navigate information and disinformation that we're all kind of being flooded with. And I think thinking that through and making sure that there are clear sources, reliable sources, trusted sources present in different ways, present on the internet, present in communities, within networks of people, is going to be very important going forward. Finally, there's a whole discussion here from our government and other places, in the US as well, people talking about building back better. These challenges have disrupted a lot of things, and we can either just struggle to get back to the same place we were, or we can take deliberate advantage of some of the disruptions to say, is there a better way to do things? And that applies to this whole discussion around the predicament of women. If this is going to actually highlight issues of domestic violence and issues of the need for support and so on, maybe some good will come from this otherwise very, very taxing situation. And that helps people cope too. If you feel like, yes, this is a terrible situation, humanity has faced this before. In fact, we've been through this a number of times, and people, even though it's taken a terrible toll, people have come through. So we need to know that message. But we're in a new environment now because of telecommunications, because of globalization and so on. So it is an opportunity to think very creatively and to bring together, when we talk about cultural psychiatry, we mean valuing local knowledge and traditions, but also recognizing that culture today is a very porous international flow of ideas and interchanges and developing new things. And we need to be embracing that very actively and thinking creatively. So that's what I would want to emphasize.
Thank you so much. It's really been a pleasure to listen to you, and not only a pleasure, but it's been so important with all the messages you've had for us, Professor Lawrence. Thank you. Very quickly, we've now managed to get Dr. Biraj back. So Biraj, you have 30 seconds to sum up the questions that were intended for you.
Yeah, thank you very much. Sorry for the technical glitch last time. I couldn't unmute on time. So I think my main take-home message, and also in response to some of the questions here, is about the importance of engaging with the communities. And I think that's a hugely underutilized resource and strength for most of us, and especially for academia, because I hate to say this, but sometimes we in academia tend to be the most conservative one, comfortable within our own cozy domain. So I think that's the message I would like to give. And another thing is also in terms of the health systems and programs, we do include the component of community engagement, but there's not much of like guidance or direction as to how we do that. But when we go and see on the ground like how things are handled, then we get some real good perspectives on that. So I would suggest that this should be a very important area for research, for academia engagement, and also for policymakers.
Thank you so much for that. A very important message. And often we say nothing about me without me. And I think that's very important in taking the community with us. So now we have come to the end of the day one of the webinar. And I have several things to say, but I will first start off by saying a very big thank you. And I hope all of you will join me in applauding all the speakers today. We've had a fantastic lineup. There have been some really good talks and information and discussions. And I would also like to thank the moderators who've also had a difficult time because there's been so much interest. But no webinar is successful without the participants. And the participants have been so engaged. You've been so active in the chat, and that is what really adds value. So a big thank you to all the participants who've been here. And also we've got nearly 90% of the participants who've stayed here after we run over almost 20 minutes over time. So apologies from us who are organizing, and kudos to you all for staying. It's an indication that this is important and interesting for everybody. And last but not the least, I'd like to thank the organizers, in particular the Empower team and Ritu Halder, who's been at the helm of putting it all together. So thank you very much, all of you. Tomorrow, please don't go away. There were a couple of questions that were raised that were very important by Professor Lars Lien about women, gender-based violence, about reproductive health, and about a number of questions that we haven't answered today that we will be taking up in the webinar tomorrow, including governance and leadership. So please follow the link and please participate tomorrow. We didn't have time to do the poll on mental health today. If we have time, we'll do that tomorrow. You'll all get a certificate in the chat box that you can download when we finish with the presentation. So, and last of all, I'd like to particularly thank Jaswant and Lawrence for getting up so early and really being there with us all the way. So thank you so much. I wish we could, take you out for a good meal in Nepal and, meet, but we'll just have to send you some virtual social food over the net, but all our good wishes, and thank you for being here. So for all of you, thank you. See you tomorrow, and hope you have a pleasant evening.
Okay, thank you very much. Thank you and namaste.
Namaste.
Namaste. Namaste.
Namaste. Thank you.
Thank you. Make sure you take your certificates.
Thank you very much, Ritu and Bernadette. Tomorrow we're starting a different time, right?
2 o'clock.
2 o'clock.
2 o'clock, yeah.
Yeah.
2 o'clock Nepal time.
Yeah.
Okay.
It's Friday and it's going to be the weekend. We can't ask everybody in Nepal to be here late.
It's perfect for us.
So I'm sorry that we can't get our Canadian colleagues to join us. It'll be the, middle of the night, but
yeah,
very good that they were here today.
Yes.
Yeah.
Okay. Bye-bye.
Thank you. Thank you,
Thank
Suresh.
you.
Thank you, Lawrence.
This is